Is it very busy with COVID now? Still it's going on there?
Yes. Well, the new numbers have come down, but patients who came like a month, patients who came about like a month back who got really sick and got to ICU, they still, remains on the ventilator, and they're still occupying most of the ICUs here.
How many ECMOs are going on right now?
We have 2 patients on ECMO right now.
Okay.
We have a capacity to run maybe 4 ECMO simultaneously, so that we have 8 cardio help. So usually we have 1 backup for every ECMO that's running. So the most we can do is 4 at a time.
We can do 2. Actually, 2 of our ECMO missions are engaged now. 2 patients are on ECMO in my hospital.
At your place?
Yes, we don't have cardio help, but we have Meadows. 2 Meadows ECMO missions. Both are occupied.
Hi, Prashant, okay. And hi, Dr. Subbareddy, Dr. Arunya.
Hi.
Hi, Arun.
Prashant, sorry, koncham delay ayindi.
Arun,
are you okay with the PPT?
Yeah. I don't know why it's just stuck at like 25%. It's not moving.
Okay.
It just says uploading and it's just stuck at like 25%.
Okay, Dr. Prashant, do you have wired connection? Here we could able to see that your internet Wi-Fi is a little weak.
My wired router is like deep in the closet, so I won't be able to.
Okay. In that case,
usually it's never.
Okay.
Or is it possible to share the presentation from your end if he sends?
No, he can actually share his screen also. There is no issue in that. He can share his screen and still he can do the PPT. There's no need to upload, but if he just uploads, it would be better.
Should I just share my screen?
Yeah, you can share your screen also, Prashant, and we can run through the PPT if it's.
Because I know this is uploading, but very slowly. It's at like 35% now.
Okay.
Or if you have the slides I uploaded last night, I think we can still go through the same slides. Well, I added a few more.
35%.
The Santosh?
Yeah.
How do I share my screen?
Okay, Prashant, there is a button which shows you to after the camera icon, there is an icon which shows as share your screen.
Okay, I'm in the different screen where it's loading my presentation.
Okay.
Should I close this screen out and go back?
Let us wait for 5 minutes. It is 35% means that must be because of internet only. Otherwise, it would have uploaded. Sharing screen would be also get the same issue because if the internet issue is there.
Actually, I'm running so many other things, and there's absolutely no issues, at least internet-wise. In
that case, you do one thing. If you open any other programs, can you close all those?
Yeah, that's better. Just stop other programs.
Consuming the internet must be sharing with other programs also.
Hello?
Now, are you guys able to see me?
Yeah, we are able to
Yes.
see you.
Okay, is the lighting and stuff is okay here?
Yeah,
Yes.
you're looking great. Everything is fine.
This is very strange.
Is it uploading? Prashant?
Yeah, it's uploading, but it's like I said, now it's at 45%.
Okay,
So it
we'll
might
wait for
take
2 to
another
3 minutes.
10 minutes, I think.
Yeah, no problem. Meanwhile, Santosh,
Yeah.
can we have the direct link also so that we can share it for others who have not registered?
Yeah, I will be sharing it with you. Okay. By the time you can introduce the speakers and we can engage the users.
Okay. I think the audience, let us wait for 2-3 minutes, Santosh.
Yeah, let's wait a little bit more. Otherwise, if this doesn't upload, then we might have to share the screen.
So, %50 is done. Actually, we had
It's at 55 now.
Okay, we had a trial run yesterday. It was, it uploaded. So we thought that it will upload in the same way today also. I think we have around 50 slides, right, Prashant? 50?
Yeah, it's about 50 slides.
Okay. Seems to have a lot of data, so it's taking time. A lot of knowledge.
Yeah, right. Yeah, I probably should have uploaded this last night.
Yeah. Anyhow, meanwhile, I hope everyone, I welcome everyone for this very important and the need of the hour, hypoxia, how to treat hypoxia, manage hypoxia in COVID-19 patients. This is our fourth webinar that we are doing in a series. Initially, we have covered diabetes, endocrinology in COVID, then we had radiology, and then we had a very wonderful webinar with Srinivas Samvedam recently on plasma therapy. So today, it's going to be on hypoxia and the different modalities of treatment of hypoxia. It's a pleasure to have Dr. K. Subbareddy, who is Chief Critical Care Consultant and Intensivist in Apollo Hospital, Hyderabad. So, sir will be moderating the session today. So, meanwhile, sir, welcome and thank you for being a part of our webinar. Hope all the participants will have a lot more information at the end of the session through your through your experience. So I hand over to you, sir. You can just have a brief of COVID hypoxia. And
Sure.
thank you, sir. Thank you.
Thank you. Good evening, all. First, let me thank Plexus Anesthesia Group for conducting such a very good international webinar on hypoxia management in COVID patients, which is very much required at this time. So, all of us are struggling with COVID patients, we are managing, and each hospital is managing hundreds of COVID patients. And when they're hospitalized, definitely they'll be needing some oxygen. Otherwise, they will be at home or in a quarantine center. So most of these patients, they'll be requiring oxygen therapy. And most of these patients are hypoxia. How to manage this hypoxia in this pandemic is each one of us managed in a different way. So we are fortunate today we are sitting in this international webinar, and then we have international speaker, Dr. Prashant, and I have seen his CV. He is also expert in ECMO program. He's ECMO program director. So, initially, when you get a patient to ER, when the patient is hypoxia, so other than medical therapy, other than giving steroids, we start oxygen, and we try to target the saturations of 91, 92, and then from there, like we use oxygen mask, and then we use Venturi mask, we use like high flow mask, and then we go to non-invasive ventilation, and then we have HFNC. We are now we are using a lot of HFNCs in the intensive care units, and then non-invasive ventilation, and then we have a new protocol called awake proning protocol. We do awake proning in these hypoxia patients, and then we go for mechanical ventilation. From there, if the patient requires, we are going for ECMO. We have different types of ECMO, and then we have different machines for ECMO. And then we have VV ECMO, and then we have VA ECMO. Most of the time we use VV ECMO. Now we are going for VV ECMO. The patient is getting longer on VV ECMO, the fibrosis, so we don't have much option other than lung transplantation. But in this pandemic in our country, how many lung transplants we can do, how many ECMOs we can do. So the best is to identify early and then try to treat them, try to prevent pulmonary fibrosis, try to manage hypoxia initially, and then we can save a lot of patients. So today, to discuss on this topic, we have Dr. Prashant. Dr. Prashant is he did MBBS graduation from Osmania Medical College, and he is a medical director of ICU Sunrise Hospitals Medical Center, that is in Las Vegas, USA. And then he is also a ECMO program director. I think he has done MD pulmonary. He is board certified pulmonary and critical care medicine specialist in US. And your slides are ready, or you are going to take some more time? So.
Probably another 10 minutes, unless we want to share the screen, and I know can keep people waiting. Arun, should we share the screen and go through the slides that way? This is at like 78% now.
Yeah, Prashant, I think whatever you are convenient with, if you are ready to share the file, screen, you can do that. That would be also the same. I think he just pressed the wrong button. He would be back. He'll be back.
Meanwhile, to keep the audience engaged, so we can keep talking about hypoxia and how to manage this hypoxia. We are unnecessarily targeting higher SpO2s, higher saturations, and we know hyperoxia is again a problem like hypoxia. So sometimes we are causing hyperoxia to the patients, and then that is triggering more pulmonary fibrosis to the patients. So hyperoxia is also dangerous. And then in this pandemic, when we are giving oxygen for so many people, so many patients, there is definitely oxygen shortage in the system, and then the oxygen prices have gone up, and then it's very difficult to get oxygen to the hospitals. So that's why we have to use oxygen judiciously. And whenever there is hyperinflammation, whenever there is hypoxia, so like there is now enough evidence to say that we can use steroids, but again, we should not misuse steroids. Usage of steroids should be like according to any guideline or protocol or any evidence. I have seen a lot of people using very high doses of steroids, and they use pulse therapy, 1 gram methylprednisolone, 500 methylprednisolone. And then when you use these high doses of steroids, we see patients going causing immunosuppression, leading to nosocomial infections, and these high dose steroids again causing hyperglycemia. Patients are going into diabetic ketoacidosis. So we have to use steroids judiciously. And again, there's a lot of controversy when to use these steroids. Whenever there is viremia phase, during first 4 days or 5 days, whenever there is viremia phase, if you use steroids, again, there is some data to say that this viral replication will be more. And viremia also, viremic phase, steroids will cause more problems, and the disease may progress. So when to start using steroids, how much dose to use, again, it depends on the patient. And then once the viremia phase is over, maybe after 6 days or 7 days, we should consider steroids. And with HFNCs, we are using a lot of high flow nasal cannulas, and again we are seeing a lot of infections, and definitely these ICU infections have gone up in this pandemic. And we are noticing a lot of Acinetobacter infections with HFNCs, maybe more humidified oxygen. We are seeing more waterborne infections with HFNCs, Stenotrophomonas and Acinetobacter in intensive care units. So what type of device you are using for giving oxygen therapy, that is also important. You have to use it judiciously, and then appropriate time we should keep escalating this oxygen therapy in the patients.
చాలా టైం తీసుకుంటుంది. ఒక 10 నిమిషాలు పట్టింది అప్లోడ్ అంతా. 10 గంటల పీపీటీ.
To share my hospital data now, there are a lot of patients, nearly 50 patients on oxygen therapy, and around 20 patients on ventilator, and 2 patients are on ECMO, and 1 patient is on ECAR, so the extracorporeal CO2 removal. So 1 patient, when we got that patient, there was no problem with the oxygenation, but his carbon dioxide levels were around 190, and the pH was 6.8. So it was more hypercapnic respiratory acidosis, hypercapnic respiratory failure. And then we used ECOR for this patient. And then this patient is on extracorporeal CO2 removal. And this patient is recovering from ECOR. And then we weaned off ECOR, and then we extubated this patient. And other 2 patients are on ECMO. 1 patient is recovering. That patient doesn't have much pulmonary fibrosis, but other patient is having severe pulmonary fibrosis. And today is the 15th day of ECMO. So these patients ultimately may require, I think, lung transplantation. Otherwise, it is very difficult to wean off ECMO from these patients. I think Dr. Prashant will have more experience on ECMO, because we started using ECMO since last 1 month. Before that, we don't have much experience with COVID ECMOs. And we used to do ECMO for H1N1 patients, but for COVID, we started recently. And the outcomes with H1N1 ARDS on ECMO were much, much better when compared to COVID, because this is causing a lot of pulmonary fibrosis. And these patients, they're requiring oxygen for months together. I know 1 patient is requiring since 2 months, 1 patient is requiring oxygen since 45 days. We don't know what to do with these patients. So you can't keep these patients in ICU for longer time. Even though they are on 10 liters oxygen, 12 liters oxygen, we try to move them out of ICUs, because we need more ICU beds for ventilator patients. And then we have to send them to a pulmonary rehab center. in the pulmonary rehabilitation center, with the good pulmonary rehabilitation in the rehab hospitals, these people, some people are recovering, some people, some elderly people, still they're requiring very high oxygen therapy for these patients, and they're not improving. And then they develop secondary infections, and then because of the usage of steroids, they're developing again fungal infections, candidemias. We are seeing bacteremias with gram-negative multi-drug resistant organisms, and then we are seeing recently I have seen vancomycin-resistant enterococci bacteremia in a patient who was on steroids and on 10 liters oxygen since last 1 month. So we are seeing a lot of bloodstream infections, and we are seeing bacteremic ventilator-associated pneumonias because of, maybe we are attributing it to HFNC. We are seeing more and more infections in HFNC when we are using for longer duration. And when you try to do tracheostomy, and then when you want to wean off these patients from tracheostomy, that is also becoming difficult. We have to wean them to either BiPAP, tracheostomy BiPAPs. Some people are developing barotrauma, and then they're requiring ICD placement, and then these patients on ICDs, on BiPAP, they're just lingering on in ICUs and then in rehab centers. So what is the end? How to manage these patients in the future is going to be a big challenge. I think Dr. Prashant's slides are getting ready. So yeah, like shortly he's going to share his screen.
No. అవునా?
Are you there, Dr. Prashant?
Sir, 2 minutes. Actually, is updating. Just give us 2 to 5 minutes. Huh?
Sure,
please.
Sure.
Sorry, I'm sorry.
No problems.
అది దాని నుంచి గ్రీన్ లైట్లో చేయట్లేదు, అప్లికేషన్ నుంచి. అప్లికేషన్లో ఐఫ్లేమ్లో వస్తుంది. ఒక్క నిమిషం, నేను ఆ లింక్ షేర్ చేస్తాను.
In my intensive care unit, the way we escalate oxygen therapy is we use nasal cannula. Initially, we give up to 6 liters with nasal cannula. Then from there, we go with non-rebreathing mask. We give high flow oxygen. And from there, if the oxygen requirement, if it goes up, then we use Venturi mask. And still, if the patient is tachypneic, if the saturations are still less than 90, then we use HFNC. And if the patient is still tachypneic on HFNC and the saturations are not above 90, and the patient is still having respiratory distress, then we go for NIV or mechanical ventilation. From there, if the patient is still, the pressures are very high, the plateau pressures are going above 30, and then the saturations are not improving, if the PaO2s are still less than 60, then we consider ECMO. And we realized ECMO, when you consider ECMO later, if you consider ECMO late in the disease part, or when the patient is developing pulmonary fibrosis, then these patients, very difficult to wean them from ECMO. So I think we have to consider ECMO much earlier. and then we can wean them from the ECMO. And we have now very good advanced ECMO missions, like Dr. Prashant was telling initially, he has cardio health missions, so which are very small and like advanced ECMO missions. So these with these ECMO missions now, they are trying to even mobilize the patients with ECMO mission, ECMO on ECMOs, and so this is how you need to escalate oxygen therapy for the patient. The participants, if they want to ask any questions, you can ask. Dr. Prashant is also there to answer. Meanwhile, his presentation is uploading. So I don't know where to look for the questions. There's the chat box somewhere. A public chat, I can see. If you have any questions, you can type in this chat box.
సంతోష్, అది సైజ్ ఎంత ఉన్నది ఆ ఫైల్, అది పీపీటీ సైజ్ కూడా చూసుకోవట్లేదు.
It is always worth waiting for such a good topic, because this is a very good topic for this current
అది
pandemic time.
పీపీటీ ఉంది కదా, పీపీటీ
During CPAP, I have one question in this chat box, that is, during CPAP oxygen therapy, saturation is maintaining well between 94 to 96, but patient is keep neck. Yes. Dr. Prashant, you want to answer? Shall I answer? When to consider mechanical ventilation? Yes. So this is a good question. Most of us are having dilemma. Now we are going for little late intubation. When during H1N1 pandemic, we were not using much NIV, and then we know the evidence of NIV in ARDS is not great. But in COVID, so from the initial data, what we got from different countries, initially from China, from Europe, from US, so the mortality when the patient goes on mechanical ventilation was very high. And when they go on ventilator, it is very high. And like initial data shows it is 90%. Later, the subsequent data from UK and US, it shows 60 to 70%. But still, in our country also, we are seeing high mortality when the patient goes on ventilator. So we are trying to prolong this HFNC or NIV for longer duration in patients, and then we are waiting to, like, we are not going for mechanical intubation, early intubation and mechanical ventilation. But if somebody is on NIV or HFNC, if the respiratory rate is 40 and if the saturations are still 90, 91, so better to go ahead and intubate and put them on mechanical ventilation. put them on ventilator. So, like if you wait for longer duration, they develop respiratory muscle weakness, and then they can have respiratory sudden respiratory arrest. So, I think we should not delay too much. In spite of your HFNC or NIV, if the respiratory rate is very high, that is the time you should consider mechanical ventilation. So again, there are two phenotypes of COVID, that is L type and H type. H is again, like H type is typically RDS patients, and these patients, like they don't improve with NIV. We need to go on mechanical ventilation. So L type, so the compliance is good. So low elastance compliance is good. H type is high elastance, and the compliance is poor. So there, that is typically RDS patients. In L type of patients, when you allow spontaneous ventilation, when you allow them to breathe spontaneously, they take larger tidal volumes, and these patients, they described another entity called PCLI, that is self-inflicted lung injury. So the patient self-inflicted lung injury. So when they're breathing spontaneously, and then when they're taking larger tidal volumes, that is leading to barotrauma. That is called self-inflicted lung injury. That's the new entity which we are seeing in this COVID time. So like these patients also, we should go on ventilator. We should sedate them. How long we can use NIV? So NIV, again, once if you're using NIV, I have seen a lot of patients, they go on NIV, and they're just lingering on NIV. They don't improve from there. And some patients, like we are managing like that, and then they are requiring NIV for longer duration, 2 weeks, 3 weeks. And some patients we decided to intubate, and these patients who are on ventilator also, they're not improving. So they are requiring tracheostomy. After tracheostomy, they're requiring BiPAP, tracheostomy, BiPAP, or with tracheostomy. So they are all like, they're very difficult to wean the oxygen from the tracheostomy. So we really don't know how long exactly to use NIV. But so when they are on, when you use steroids, when you use high-end antibiotics like polymyxins, so all these things were causing critical illness pneumonitis. Weakness and requiring.
Prashant, we can.
Dr. Prashant, you are ready?
Okay. Finally, after all the technical snacks and glitches, we have got it. I hope everyone can see the presentation. You have to press on the right side screen corner the presentation, and you can enlarge it. Sir, can you see Dr. Subbareddy?
Yes, sir, I can see, sir.
Okay, thank you, sir. Thank you. Prashant, yeah, you can go ahead. Yeah, I can hear you, Prashant. We can all hear you. Yeah.
Hello.
Yeah, Prashant, you can start the session. Prashant, you can start the session. Okay. Finally, after all the technical snacks and glitches, we have got it. I hope everyone can see the presentation. You have to press on the right side screen corner. Yeah, Dr. Prashant. Sir, can you see Dr. Subbareddy? Yes, sir, I can see. Okay, thank you, sir. Thank you.
Dr. Prashant, can you hear us? I think there is a problem with this connection.
Yeah, exactly. There is some, I think a net connection is better in India. Yeah, Prashant, you can start the session. Prashant, you can start the session. Okay. Finally, after all the technical snacks and glitches, we have got it. I hope everyone can see. Oh my God.
we're still having some technical issues. Sorry. Okay, there you go.
Yeah, Prashant, we can hear you.
We can see.
Okay. Now, in the early December 2019, we had our first cases of pneumonia that were identified in Wuhan, the capital of Hubei province in China. After initial investigations, they found out that this is caused by SARS-CoV-2. Those were the first reported cases. And they classified this SARS-CoV-2 as a novel member of the enveloped RNA beta coronavirus family. And they named it SARS-CoV-2 because its similarities with the initial SARS-CoV-1 and the Middle Eastern respiratory syndrome viruses. Since then, it has rapidly spread into these pandemic levels, and we've seen our share back here in the United States, and India also is currently going through the pandemic and seeing extensive number of cases of COVID pneumonias. COVID can present in different ways and with different lung manifestations. Most common one I would say is still pneumonia, acute respiratory distress syndrome, pulmonary embolism. People with COVID pneumonias are unusually high risk for having thrombosis and pulmonary embolism. Pulmonary hypertension, usually in the beginning, it's a reversible kind of pulmonary hypertension when they're in the acute phase. And when, after recovery, they still have some residual effects of pulmonary hypertension as a chronic problem. Chronic hypoxia, some of the patients do improve after the treatment of pneumonia and ARDS, but some of them are dependent on oxygen for a prolonged period of time. And they may have to go home on oxygen for quite some time until the lungs recover. Pneumothorax is kind of a secondary effect after patients develop ARDS from COVID-19. And when the lungs are recovering and then they go into a fibrotic stage and become stiff lungs, with all the positive pressure ventilation that we do, some of them develop pneumothorax also. Secondary bacterial infection, once the lung is destroyed and damaged from the COVID pneumonia, then it's very easy for a secondary bacterial infection to set in and cause more damage. Now, the common point to all these things are, most of these patients, do have hypoxia on presentation. And that's what we'll talk about today. Now, this slide shows, how do we define hypoxia? Now, the arbitrary number of 90, has been changing. Some people accept 88, some people accept 92. Is it really the pulse oxy number that is important? Has been explored, and the concept of tissue hypoxia in these patients is probably very important, more important than oxygen saturation that we measure on their pulse oximetry. Now, the idea of tissue hypoxia is, are the end organs and is the tissues getting enough oxygen supply? The question is, at what number of the saturation is the tissues are actually getting enough oxygen? One of the other concepts that kind of ties up into these things is the oxygen delivery and the oxygen consumption. Now, usually in a normal human being, we have oxygen delivery is 5 times that of oxygen consumption. As long as our delivery to consumption ratio remains above 2:1, we still are in aerobic metabolism and we are okay. So there are many patients with saturations less than 85%, sometimes even up to 80%, have adequate DO2 by VO2 ratios and do not manifest signs of tissue hypoxia. So this kind of brings us to a thought, should we allow patients to have oxygen saturation lower than 90% and still be comfortable? That's a very difficult concept for all of us, because we are all used to watching that number and trying to keep it above 90. And sometimes we might do more harm than benefit by trying to reach that number.
Prashant, sorry to interrupt.
Calculate oxygen delivery, oxygen consumption, and look at the ratio. And if the lactic acid is normal, then having a lower saturation is probably okay in these patients. This is mainly true in my younger patients who have preserved cardiopulmonary reserves, who can tolerate lower oxygen saturations. Now, this is a slide that shows.
Prashant, can you hear me? Actually, we are not able to see the PPT.
alveolus,
moving.
and to the right of the screen is a lung that has been damaged from COVID-19 and presenting as an ARDS.
Can you hear me?
On to the left side, if you can see on the bottom, you can see the alveolar lining, and then there is alveolar epithelial cells, alveolar basement membrane, and blood vessel, and intact capillary membrane. Hello?
Can you hear us? Lights are not moving.
Actually, we are only able to hear your voice and see the camera. Just Prashant, can you just upload the PPT now? Yeah, just upload it and then come back, and then we can have the we can start from the second or third slide, because you blocked at the first slide itself. No, you have muted yourself.
Okay, how about now?
Now we can hear you, right? Now we can hear you, right? Yeah, Prashant, I think you can start off from the third slide.
We'll start back at this slide. I'm not sure if you were able to see this slide before.
Yeah, actually, none of us were able to see any slides.
Shows a normal alveolus on to the left of the screen and an injured alveolus on the right of the screen. Now, on the left of the screen, you can see on the bottom here, you can actually, this is the alveolar surface, alveolar epithelial cells, which has your type 1 and type 2 cells. You have your basement membrane, and this is the interstitium of the lung. This is the endothelial surface, and here is your blood vessels or blood cells in there. So the oxygen exchange or the gas exchange has to happen from this surface across this membrane into the blood for oxygen to be delivered into the body and for the carbon dioxide clearance. Now, on the right side of the screen, once the alveoli is damaged from ARDS or from the COVID pneumonia, you can see that the alveolus is filled with highly enriched membrane, and that is very impermeable to carbon dioxide transport. You can also see that the interstitium is widened because of the edema and infiltration of neutrophils and macrophages. You can see a damage to the endothelium as well. And here are all the cytokines and interleukins that are contributing to the severe inflammation and capillary leakage as well as fibrosis eventually. Now this is where we have, no matter how much oxygen we push through into the lung to this point of the alveolus, there is no way for the oxygen to get through this membrane into the blood vessels, or for the carbon dioxide to go the other way. This again talks about the pathophysiology of hypoxia. Now, the biggest issue, the reason for hypoxia is impairment in your gas exchange. Now, as we talk, there are three important things that needs to happen for an adequate gas exchange. One is an alveolar ventilation. Air needs to come in and get out of the alveolus. There needs to be a pulmonary blood flow, where your pulmonary venous blood flow and pulmonary arterial blood flow has to happen. There has to be a proper matching of your ventilation and your perfusion so that there is an adequate exchange of gases. And once the oxygen is get into the blood, the oxygen is bound to your hemoglobin, and the oxygen dissociation curve determines if it can be unloaded in the tissues. Anytime there is a disruption in alveolar ventilation or in pulmonary blood flow, or if there is a mismatch, or if the oxygen dissociation curve is shifted towards left, then there is a problem in delivering oxygen to the tissues, and people develop tissue hypoxia. Now, one of the extreme examples of a VQ mismatch is a shunt, where you have no ventilation, where V is 0, meaning there's no air coming into the alveolus, but the blood is coming and going and not picking up any oxygen. It behaves like a shunt. The other extreme of this VQ is a dead space ventilation, where you have no perfusion happening, air is coming in and going, and still no gas exchange is happening, and that's called a dead space ventilation. Now, everything else falls in between these two as a spectrum. Now, there are certain specific pathophysiology elements happen in COVID-19 pneumonia or ARDS. There is increased intrapulmonary shunting because of significant atelectasis from loss of surfactant in COVID patients. Also, the VQ mismatch is more pronounced because of loss of hypoxic vasoconstriction. Now, usually our pulmonary blood vessels have a protective mechanism where if they detect hypoxia in that part of the lung, the pulmonary blood vessels vasoconstrict so that the blood is all directed to the normal lung. And because of that impairment, because of COVID effect on the ACE receptors, this mechanism is impaired, and there is a higher degree of VQ mismatch in patients with COVID pneumonia. Also, there's a shift in that oxygen dissociation curve we talked about towards the left because of the action of COVID on the heme molecule, and that also makes it difficult for oxygen to be delivered to tissues and cause hypoxia. The dead space ventilation also happens in a significant part of our patients because of the microthrombi. There has been many case reports and autopsy reports showing microthrombi in many blood vessels in these patients, which all work like a dead space ventilation, causing, leading to hypoxia. Now, there's been a term that's been thrown around called happy hypoxia. We hear this a lot these days. Usually what it means is patients have profound hypoxia without proportional signs of respiratory distress. So if you see them, they don't have any signs of shortness of breath, they're not hypopneic, they're not in distress, but when you measure their oxygen numbers are extremely low. Now, many a times, hypoxia in itself does not present without other signs. So patients usually come to the hospital with generalized weakness, myalgias, fatigue, fevers, and when you measure their oxygen numbers, then you find the saturation to be very, very low. Now, for someone to develop dyspnea, usually there are multiple sites in our body that actually trigger centrally mediated dyspnea, and one of them is the stretch on the J receptors that are in the lung. So the hypothesis was the lung parenchyma is initially preserved, and the lung is not stiff, so it has enough gas volume coming in, and there is no stretch receptors that are activated, so patients don't have dyspnea, but their hypoxia is all related to pulmonary vascular flow rather than the lung parenchymal disease. So their lung, if you do a CT scan, may be completely normal, or a chest X-ray may be normal. The lung compliance is normal, but because of the microthrombi and blockage of the pulmonary vasculature and the VQ mismatch that happens because of the dysregulation of the pulmonary vessels, they are hypoxic. But again, they don't perceive it, and there's no dyspnea. Now, there's an interesting concept called patient self-induced lung injury that usually comes when patients are very tachypneic and increased inspiratory drive. In these patients, because they do not feel the symptoms of dyspnea, you see a lesser incidence of patient self-induced lung injury in these people too. And these people may benefit from prolonged high-flow nasal cannula or a non-invasive ventilation, and they are candidates for late intubation because they do not have this extra drive that's going to cause more lung damage. Now, once patient is hypoxic, we've determined they have hypoxic. Now we need to provide oxygen supplementation or respiratory support to these patients. Now, these are all the modalities that we have, how we can provide oxygen to these people. From top to bottom is, from someone with a mild hypoxia to someone with severe degrees of hypoxia. The first one is, everyone knows, is a simple nasal cannula. You can give up to usually 6 liters per minute. And then the simple face mask for people who cannot tolerate nasal cannula, people with nose burns or face burns and stuff. Venturi mask, this is probably a more accurate way of delivering, what concentration of oxygen you want to give. The problem is it's a mask that usually prevents patient from talking, eating, and taking their medications and stuff. Non-rebreather mask is similar problems. It can provide 100% oxygen, but there's inconvenience of putting a mask on their face, and the patients can't eat or can't talk properly. The next one is the high-flow nasal cannula. We'll go a little bit more into detail about high-flow nasal cannula, because that has been a significant increase in use of high-flow nasal cannulas in COVID patients, and we've seen good results with the high-flow nasal cannula. Then comes your non-invasive positive pressure ventilation, either CPAP or BiPAP. Then comes invasive ventilation, and if you still cannot deliver enough oxygen, then we have rescue therapies like extracorporeal membrane oxygenator or ECMO, and there's pulmonary vasodilators called inhaled nitric oxide that can also help to transiently improve oxygen in patients who other modalities have failed. So once we started seeing COVID patients in our hospital, a lot of things were unknown, and there has been a rapidly developing evidence, which is all largely case reports based or case series based and based on anecdotes. And we've shifted our management protocols, multiple times until we actually have a better understanding of pathophysiology, as well as how these patients behave. So the biggest questions we have, or we had when we treat patients with COVID-19 pneumonia is, should I use a simple nasal cannula, or should I use a high-flow nasal cannula, or should I use a high-flow versus a non-invasive? Even in non-invasive, is CPAP better or is BiPAP better in these people? When to intubate these patients? In the beginning, the whole concept was to intubate patients early when they reach to 6 liters of nasal cannula, and now that has changed. So which patients we can wait and which patients we need to intubate early? Once we intubate, do we give a high PEEP or a low PEEP ventilation? Do we use a low tidal volume or a high tidal volume ventilation? Is there a role for ECMO in COVID patients? And then the last question is tracheostomy. Do we do an early tracheostomy or do we do a late tracheostomy in these patients? So these are the big questions that most of us managing COVID patients with severe hypoxia have, and we'll try to address each one of these things through our talk today. The first question was simple cannula versus high flow nasal cannula. Now, both of them have their advantages and disadvantages. Now, simple nasal cannula is okay if someone is, has a mild hypoxia, someone requiring 2 liters to 4 liters of nasal cannula or up to 6 liters of cannula. Simple nasal cannula works, very fine, and you can humidify the oxygen, and the patients are comfortable. The biggest disadvantage of simple nasal cannula is if someone is tachypneic or someone's inspiratory flow rates are 20 liters, 30 liters per minute, what we're giving will never be able to match the inspiratory flow rate of the patient. So what that does is, because you're only providing 6 liters per minute to the oxygen, and when the patient is breathing, say 20 liters per minute, the excess amount of flow comes from the room air. So that dilutes your oxygen concentration, and you're never actually giving 6 liters of oxygen if the patient is breathing 20 or 30 liters per minute. Now that's where the high flow nasal cannula comes in. It's mainly for patients who have tachypnea, have increased work of breathing, whose inspiratory flow rates are much faster. Then we can try high flow nasal cannula in these patients, and here you can increase the flows up to 60 liters per minute. The disadvantage is it's not available widely in the hospital, so the resource and the cost is an issue. And there is a theoretical increase in aerosol generation with the high flow nasal cannula. In the beginning, during March and April, when we started using high flow nasal cannulas, it was one of the theories at the time that the high flows and BiPAPs would generate more aerosols and increase the risk for healthcare workers, which now I think more people are more comfortable using them, either because some of the data has come out where it showed that it's not a big difference between the aerosol generation, and if you actually take enough precautions where you put a mask on patient and we have an N95 mask and the patient is in a negative pressure room, usually the risk of spreading the infection to healthcare workers is pretty low. So this is one of the high flow machines, manufactured by Paykall, and it's called Airvo2. And on the screen, you can see, these are where we dial in the buttons. But the 3 numbers that we're seeing, 31 degrees, that's where the temperature control happens for the gas. And we can see the flow is 60 liters per minute, and FiO2 is set at 52%. So these things we can adjust based on the patient's needs, and this FiO2 can go up to 100%. Usually the flows are max is 60 liters per minute, and the temperature we control, and there is a humidification also. So the 2 major companies that actually manufacture high flow nasal cannula, one company is called Vapotherm, and this is their high flow machine. And Paykall has 2 models. One is the OptiFlow, and one was the other one that we saw, the Airflow. All of them, the principle is the same. They all provide humidified, heated gas, and at a much higher flow rates than usually a simple oxygen or simple nasal cannula. Now, you might hear 3 different terms in high flow oxygen therapy: HFOT, or this is high flow oxygen therapy. This is high flow nasal cannula. This is high flow nasal oxygen. So they're all the same. They're all different names, but it's the same modality. Again, what it does is oxygen in conjunction with compressed air and humidification is delivered to the patient at rates which are much higher than a traditional oxygen therapy through a simple cannula. And you have a blender connected to the wall outlet, you have a humidifier, you have a heated tubing, and you have a cannula. And those are all the components of your high flow. And what it does is it takes the gas, it heats it up to 37 degrees, and then adds 100% relative humidity, and then delivers oxygen at concentrations of 21% to 100% at different flow rates. It can go up to from 30 liters to 60 liters per minute. Now, as we talked, there are various advantages to high flow nasal cannula, and it has become more and more popular, mainly because it can provide much higher flows to the patient. It's much more comfortable to the patient than non-invasive masks like a BiPAP or a CPAP mask. They do provide some positive pressure, so it not only provides the oxygen, but it also provides some work of breathing help. So patients who are tachypneic or have increased work of breathing, get some support from the high flows that are provided by the high flow cannula. And there's more and more studies every day, including last week on the Lancet, we have published data showing that high flow nasal cannula is beneficial compared to other modalities and have decreased the need for mechanical ventilation also in COVID patients. The common settings we start is usually if someone is so hypoxic, we start with 100% oxygen FiO2 and start at 45 liters per minute. That's somewhere, the middle pace of the flow. If we start right away at 60 liters per minute, the patient feels extremely uncomfortable because it's the air that's blowing through the nose right away. So we can always start low and gradually ramp up the flow to match their patient's flow. And then initially, once the flow is not so high, the patient can tolerate it better, and then we gradually increase the flow, try and match what patient's inspiratory flow is. Oxygen can always be titrated to keep that saturation about 90%. And then as we talked, the air is humidified and heated also for patient's comfort and so that the nasal mucosa is not dried up and they have epistaxis and stuff, so that can be prevented. Mucosal ciliary function also remains intact when you have humidified and heated oxygen. These are some of the guidelines from one of the big societies regarding high flow nasal cannula in COVID patients. Again, in the beginning, as we said, there was a big fear of increased spread of coronavirus from patients to healthcare workers if we use high flow nasal cannula. So some of the big societies have come out and said that it's okay to use high flow nasal cannula or prefer to use high flow nasal cannula as long as we have adequate PPEs and adequate infection control precautions are taken. This does not, increase the spread of infection. And after, the first one is Australian New Zealand Intensive Care Society. The next one is by SCCM, and the last one is WHO guidelines. And all of them are in sync in kind of supporting the use of high flow nasal cannula in patients with COVID-19 infection. So the next question we had is, if someone needs some positive pressure, is tachypneic and is hypoxic, should I choose high flow nasal cannula or should I use a non-invasive mechanical ventilation, which is usually a CPAP or a BiPAP machine? So again, here also, not one answer doesn't fit all patients, and we have advantages and disadvantages for both modalities. Now, high flow, we already talked about some of the advantages of high flow nasal cannula. One of the big things is patient comfort, and when the patient can have just cannula in the nose, his mouth is open, so he can eat, he can talk, he can take his PO medications. Patients can ambulate, participate in physical therapy, and also do self-proning more easily if the patient is on high flow nasal cannula. CPAP and BiPAP, the main benefits or advantages is if someone has underlying COPD or has underlying acute pulmonary edema or a CO2 retention, then CPAP and BiPAP are probably better modalities over high flow nasal cannula. So those are the couple of situations where we directly start them on BiPAP therapy instead of high flow nasal cannula therapy for if we have to blow out some carbon dioxide, or if they have underlying pulmonary edema where they need a higher positive pressure to drive the pulmonary edema out or to support COPD exacerbations as well. Now, the disadvantages of CPAP or BiPAP is, you have a tight mask sitting on patient's face continuously, and so there is no break for the patient for him to be able to have his nutrition or take his PO medications. And these masks over a period of time do cause pressure ulcerations, and we've seen patients' nasal, bridge kind of got necrotic to a point where, someone was on a BiPAP for 8 days, 9 days continuously without nutrition, without medications. We are able to keep saturation up, but then the other effects of wearing a continuous BiPAP are pretty brutal. Now, once if we decided to go with the non-invasive mechanical ventilation, then the question comes: is BiPAP better or CPAP better in COVID patients? So once patients have COVID pneumonia and ARDS picture, you definitely need higher airway pressures for longer period of time for them to be able to get enough oxygen. So we do start patients with a CPAP, which kind of gives you a higher pressure for a prolonged period of time. So this is a continuous positive airway pressure. So I put in a fixed pressure on these patients, and the machine delivers this fixed pressure continuously through the patient's inspiration and expiration. So that drives your mean airway pressure much higher and keeps it there, and that helps in oxygenation. Now in the BiPAP or the bi-level positive airway pressure, we set an inspiratory pressures and we set an expiratory pressures, which is much lower. And it cycles through this high pressure to low pressure. Now the advantage here is you're not pushing so much air when the patient is trying to exhale. So when you drop from IPAP to EPAP, improves the patient's comfort where he can breathe out and then goes back to IPAP. But the problem is you cannot maintain that high pressures, mean airway pressures for a long period of time, and you might not be able to provide enough oxygenation like you can provide with the CPAP therapy. So if someone's do not have very bad ARDS, I would probably start with a BiPAP therapy. That way it's comfortable for the patient, gives the IPAP time and gives the EPAP break for the patient to breathe out, and much more comfortable and can tolerate it for much longer. And if someone is, has pretty bad lung disease and oxygenation is an issue, then we can try a higher pressure on the CPAP, for a day or two until we know which way the patient is moving. If the patient is getting better, we can switch him back to BiPAP or back to high flow cannula. If the patient is not improving, then we proceed with the intubation. This is a diagram, a picture showing how or the difference between a CPAP and a BiPAP. You can see the blue line is the CPAP. Now here we set a pressure at 20 centimeters, and it delivers 20 centimeters throughout the cycle without any break. So that keeps your mean airway pressure also, around the same zone, driving the oxygenation in. Now, as opposed to BiPAP, where your EPAP time is here and your IPAP is here, and it cycles through IPAP and EPAP. So the amount of time spent at a higher pressure is much lower as compared to the CPAP therapy. But again, this gives the patient this break where he can actually breathe out during those times. Now, these are various masks or devices that we can use with CPAP or BiPAP. Now, the first one is just a nasal mask, so that sits on around the nose and your mouth is left away out. Next one is nasooral mask. This one covers both your nose and the mouth. This one has probably the best seal without any leakage. Now in the nasal mask, you have your mouth open and there can be a significant leak and increase in aerosol generation in the nasal mask itself. Now here, this is similar to a high flow nasal cannula or a nasal pillows, and you can still provide positive pressure. And this is a face mask, and this is a complete helmet mask, I should say, which you can provide positive pressure using the CPAP or a BiPAP machine. So a little bit about that helmet, the last picture that we saw. We do not have much experience at our hospital, but I think European, Italian, all ICUs, they do have extensive experience with helmet positive pressure support, and they have some good outcomes as well. I know in India, Arun, I think, also has some experience with using these helmets. So the concept is the same. You provide positive pressure within a closed environment with a minimal leak. Good part is these helmets are transparent, so you can see the patient can see you, and it has a rubber collar neck seal, so it does not allow air to go in or go out. It improves the tolerability for the patients, reduce the complications for ventilation. It's not commonly used in patients who have CO2 retention, or the patient neurostatus or mental status is not so awake. I don't think it's one of the good modalities. But the advantage again is to decrease the risk of aerosol generation because it's a closed setting around your face. And with our CPAP and a BiPAP, patients probably can tolerate it better because the mask is not sticking on your nose or face for a long period of time. So the next big question is, do we intubate them early? Do we intubate them late? Again, in the beginning of the pandemic, we were intubating patients very early based on the anecdotal data from China and from New York. So the next big question is, do we intubate them early? Do we intubate where people were quickly deteriorating from 2 liters cannula to 6 liters to, based on high quality clinical trial evidence. And then, we realized that we're doing more harm by intubating, putting them on the ventilator support very early. And now there's a shift in paradigm in treatment of these patients to more, late intubations and using the other modalities like HIFO and BiPAP before we, intubate these patients. Intubation may be beneficial if someone has a very high respiratory drive, meaning if the patient is really working hard to breathe. In those patients, it's probably better to take over their ventilation and cut down that respiratory drive, because that can cause ventilatory, the lung injury. Also, someone who's requiring prolonged CPAP or BiPAP support and, they're not showing any improvement in a day or 2 days, then, it's probably a good candidate for intubation at the time. So these were some of the problems we encountered when we were intubating patients early in the course of the pandemic. At the time, the test results would come like 2 to 3 days after we send the test. So in the beginning, a lot of suspected cases were intubated, but then later their tests came back negative. So they had other pneumonias or other causes for ARDS. And these patients were intubated, because of the suspicion of COVID-19. Now we know that many patients recover with high flow cannula or CPAP therapy without ever requiring intubation. So those patients also we were intubating at the time. In hospitals where resources are limited, you're actually taking away a ventilator from a patient who can actually benefit from it. If you're intubating every patient of COVID who comes in, you might not have enough ventilators for other patients who treat other, respiratory problems. Also, once you intubate the patient, there is a ventilator-associated lung injuries that can happen, bariatric trauma, volume trauma, Wheelies, and VAPs. So ventilator is not a benign thing. It comes with lots of problems. Now that we have to look at it against, whether the patient self-induced lung injury, like if you delay the intubation and patient is breathing fast for 2 days, 3 days, now that rapid respiratory drive patient himself can cause damage to his lungs. So if you delay too much, there's a risk for this injury, patient-induced self-injury. If you do an early intubation, there is a risk for ventilator-associated lung injury. So it's ultimately a clinical decision depending upon how fast the patient is breathing and how fast he is deteriorating. So now it's obviously like anything else, it's a clinical judgment, and I don't think early works for everyone or late works for everyone, and we just need to customize it based on individual patients' dynamics. So currently now we intubate early on patients who there is a rapid deterioration. When you see the patient comes in, they initially on 2 liters oxygen, within hours they go to 6, and then they require high flow and a BiPAP, and they're not improving even on a BiPAP. Then we know their pathways were much faster, and we early intubate these patients. If someone has a significant hemodynamic instability associated with hypoxia, someone is on 2 pressors, 3 pressors, shock lactic acidosis, those patients also we intubate them early. Or if someone comes in or presents with multi-organ failure, renal failure, fluid overload, cardiac failure, arrhythmias, then those patients are also require early intubation. So once again, these are the 4 reasons why anyone gets intubated, whether COVID or not. If you have trouble oxygenating, if you have trouble ventilating, meaning clearing your CO2, if you have trouble protecting your airway, or if you want to reduce the work of breathing. So COVID-specific oxygenation is ARDS patients. Ventilation is when they it's extremely bad atelectasis causing death by ventilation, and neuro changes where they can't blow out their CO2. Airway protection, we have seen some COVID patients who come purely with depressed neurosystem, stroke-like presentations. In those patients, we intubate even though their lungs are relatively okay. and also to reduce the work of breathing. Some people, even with preserved oxygenation, have increased work of breathing, and those patients also get intubated. So those are the 4 main reasons for someone to get intubated with COVID pneumonia. Now, once you intubate patients, there are various modes available on multiple different ventilators. There are now probably 20 different companies make 20 different ventilators. US might have different ones, but ultimately, I think the common modes of ventilation are either volume assist control, pressure assist control. We've used a lot of pressure regulated volume control or airway pressure release ventilations. Pressure support ventilation and proportional assist ventilation, not so much. High frequency oscillator ventilation, this is kind of a rescue mode when everything else has failed. And people have tried it. Only anecdotal data and transient improvement in oxygenation, but no real improvement in outcomes. But people do use high frequency oscillation ventilation, especially in children. It's used quite frequently. So again, most of the modes in the ventilator are divided between either it's a volume control or it's a pressure control. So at any point of time or at any point of lung compliance, either we can control the volume or we can control the pressure. Once you control the volume, meaning if you want to give a fixed delivered amount of volume, you cannot control the pressure. If the lung is a stiff lung, for the same amount of volume, the pressures go up very, very high. And if the lung is a compliant lung, then for the same amount of volume, the pressures might not go up so high. So if my primary goal is to give a fixed amount of volume and minute ventilation to the patient, the mode I choose is usually a volume control mode. Now, the pressure control mode is, as the word says, you're trying to control the pressure. Now, in ARTSNet trial, one of the biggest a positive thing it was to keep mean airway pressures less than 30 centimeters. Now, how do I make sure the pressure never crosses that number? Is I can pick pressure control and set the pressure at 30 centimeters or below as a pressure control mode. The problem there is I cannot control the volume. So again, if it's a stiff lung and I'm giving 30 centimeters of pressure, they might be only getting 150 ml of tidal volume, as opposed to a compliant lung where they might get 500 ml of tidal volume. So both of them have drawbacks, and both of them, have advantages. So looking at the underlying patient, we can pick one over the other. There is no single mode that has been shown to be beneficial or better over the other mode in COVID patients, or even any ARDS patients for that reason. So it's mainly the patient's respiratory mechanics determine which mode we choose to ventilate these patients. So a couple of common, volume control modes are, you might see CMV, which is the controlled mechanical ventilation, or assist control ventilation or volume ventilation. Pressure control, the common modes are pressure AC, PRVC, which is a pressure regulated volume control mode, and APRV. So we are using more and more of APRV. It has a similar concept to the CPAP that we talked earlier, where you can maintain the high pressures for a prolonged period of time, and then you do a quick release, and then you go back to that high pressure for a prolonged period of time. And this drives the mean airway pressures to the number where you want it to be, and for a prolonged period of time, and kind of makes it like an inverse ratio ventilation also, and provides better oxygenation. So we've done more APRVs in the recent times, I should say. But these are the two favorite modes in patients with ARDS and COVID: the pressure control mode and the APRV mode. So if we choose a volume AC, we're just going to run through a few initial settings that we choose. So volume, again, based on the ARTSNet protocol, we try to keep the tidal volume usually less than 6 ml per kilogram. So in the beginning, we may start at 8 to 10 mLs per kilogram of ideal body weight, and then titrate it down to usually less than 6 ml per kilogram. So that will be the goal in the volume AC. We start with highest oxygen to start with. Once we intubate the patient, we start them on 100% oxygen. Usually, since we use a rapid sequence intubation and these patients are paralyzed, we keep their respiratory rate slightly higher at 16 to 20 per minute in the beginning until they start with their spontaneous breaths. PEEP, we start anywhere from 5 to 10 centimeters. Usually, if I'm starting 100% oxygen, their hemodynamics are okay. We start with the PEEP of 10 and then titrate it up or down based on their oxygen requirement. We also have to set an eye time. Again, for a rate of 15, then 1 second is eye time. You get 3 seconds for your exhalation or expiration time. Pressure regulated volume control mode. So this has a little computer chip inside the ventilator, and what it does is, so we set a target volume similar to 6 to 8 ml per kilogram, and the machine picks a pressure to deliver this amount of volume, and it constantly adjusts its pressure to try to reach this volume based on the previous 3 breaths. So it calculates the lungs compliance and how much volume was delivered in the past 3 breaths, and if the volume was low than what we set, then it gradually increases the pressure to reach this tidal volume target. So it's you're basically controlling pressure and volume in this mode. So there is 2 patient at this better over controlled modes. So this has also become more popular these days in patients with ARDS and COVID pneumonia. The rest of the settings are about the same. We start with 100% oxygen, rate about the same, and PEEP and eye time is about the same. Now the pressure control mode, this is pretty straightforward. Again, we put in a fixed pressure. The reason why we choose 25 to 30 is again because of the Arsenet protocol. We try to keep airway pressures less than 30, but we want to keep the highest close to the point of 30. That way we have the high driving pressures, and rest of the settings remains the same. Now here again, we are fixing the pressure, but the volume is not fixed, and volume can change with every breath based on the lung compliance.
Hello, sir. Sir.
APRV or airway pressure release to ventilation. This is again one of the modes of inverse ratio or ventilation where you have a prolonged period of time where the pressure is maintained at 25 to 30 centimeters. And that so the T high is the time where how long the P high lasts, and then T low is the time where it gives that release to the P low level, and then it goes back up again to P high. I wish I had a diagram of the ventilator, but so the concept is again to keep that P high at that high level for a prolonged period of time, and then give a little break for the ventilation to happen, and then you go back up there and maintain at the same level. And this has pretty good success rate in patients with severe ARDS where we could not oxygenate with volume control or pressure control. APRV works very well in these patients to at least help improve oxygenation in the beginning. For the sake of time, since we started a little late, I think we're going to skip the troubleshooting part. Okay, so once we put patients on the ventilator and then their oxygen is still low, what are the things that we can do on the ventilator no matter what mode they're in? One of the simple things and easiest thing we know is to play with the FiO2. So if their oxygen is not already set at 100%, that's the first thing to do is to go up on their oxygen. Simultaneously, you increase the PEEP as well. So Arsenet protocol again gives you for what FiO2, how much PEEP needs to be delivered. There is a high PEEP strategy and a low PEEP strategy, and then based on the table we can set the PEEP according to where the FiO2 is going. We can adjust their descending volume. So if someone is in a volume control mode, we can increase their volume. If they're on a pressure control mode, we can increase their pressure target that we set at, and that improves the distension and pushes more air and can improve the oxygenation. we can do an inverse ratio ventilation where you can keep increasing your I time and decreasing the E time, and that also gives more time during inspiration or inhalation and providing more oxygen during the time. There are various recruiting maneuvers that we do to try and recruit collapsed alveoli to help open up and improve the oxygenation. Or the last thing we do is disconnect patient from the ventilator and have to ambu bag until help arrives, or we get an X-ray to find out what happened, or the ventilator itself is a problem. But these are the things that we can do in patients where you're still having trouble oxygenating them despite being on the ventilator. Now, CO2 clearance problem, again, there are things that we can do on the ventilator to blow out their CO2. One of them will be to increase their alveolar ventilation. You can do that by increasing the respiratory rate or increasing the tidal volume. Respiratory rate, is probably the first one we go, because we want to keep that volumes less than 6 ml per kilogram. But once it reaches up to 30, somewhere in that range, your benefit of your alveolar ventilation actually does not go up, because you're also multiplying the dead space ventilation for lower volumes beyond a point. So you can go up on the respiratory rate up to 30, but then after that you have no choice but to increase the tidal volume if you really want to blow out some CO2. Other thing is to decrease the I time. That gives more time during E, and then you have more time to blow out the CO2. And this concept has been there for a long time, permissive hypercapnia, where we accept higher PCO2 levels, even if that means drop in a pH. You can go as low as 7.1, 7.2, and you're okay with that. You try not to blow out the PCO2 by high ventilator settings that can cause damage to the lungs. So we accept a higher PCO2 level as long as your hemodynamic stables are okay and your pH is not too low, or usually 7.1 is kind of a magic number we follow. Now, again, there has been a lot of talk about how ARDS patients are different in COVID compared to non-COVID ARDS. One of the theories that were proposed by Gattonini, from Italy. So they proposed that the lung in COVID patients has two phenotypes. One is a type L and one is a type H. Now, L stands for low elastance. That means it's a more compliant lung. And these lungs have, low pulmonary ventilation perfusion ratio. And these lungs also, the weight of these lungs is low because they're not stiff, they're not boggy, and they're easy to recruit. Now, the type H is the high elastance values, meaning these lungs are stiff lungs. And there's a lot of right to left shunting that's happening because of severe atelectasis. Lung weight is heavy now because of all the atelectasis and the hyaline membrane deposits. And their recruitability is also different from compared to the type Ls. The problem is, the lungs don't behave one way or the other, like it's a spectrum. So there are some of the patients have type L and some of them have type H. There are some of the patients have a combination of L and H. So certain parts of the lung can behave like an L phenotype and certain parts of the lung can behave like a H phenotype. Same patient could have been in the L phenotype in the beginning, and with time has progressed to the H phenotype, either secondary to the damage from the ventilator modes or the higher ventilator settings where we do. So it's extremely hard to differentiate patients between L and H, even though it's a very interesting concept. It's hard to delineate each patient into these phenotypes. The only one way of knowing lines, tidal volume pressures minus P. Once you divide that, it gives you a compliance of the lung. So if your lung compliance is very low and it's a stiff lung, then you fall into this mode. And if your lung compliance is very well, then you fall into type L. So that way you can decide who can get high P and who can get low P. We need to watch these patients very closely, and we cannot just leave them on either high or low and let them run for the rest of their course. as the disease progresses, either for betterment or worse, the lung either can become more stiff or more compliant. And the patient can shift from one to the other. And then, your higher PEEP or lower PEEP then may be damaging to the patient. And so we might have to constantly adjust both the high and the low PEEP modes on these patients. I'm sorry, excuse me. So the next big question is ECMO. So we've done everything and we've gone through the modes of the ventilators and we've adjusted FiO2 PEEPs, we put them on APRV, high PEEP, and we're still not able to oxygenate the patient. Is there a role for ECMO in these patients? So ECMO, even prior to COVID-19 pandemic, was going through back and forth in the studies whether there's a real benefit of ECMO in mortality, and there have been some controversial studies, where some of them did not show a mortality benefit and some of them did show a mortality benefit. So when we came to this COVID pandemic and we were not able to oxygenate patients, this was the next step to go, because theoretically we know we can provide enough oxygen and clear this CO2 with our ECMO machines. So we did start with ECMOs in the beginning of the pandemic and did not have very good outcomes. Then we have more literature coming from different parts of the country and outside the country also who used ECMO, and some of them did have some good beneficial outcomes. Now, when we dissected out, the key factors are you have to pick a patient who's relatively young, who has a single organ involvement, typically only the lungs, and their pre-intubation course. If someone was sick for 10 days and then was on a BiPAP support for another 10 days and then gets intubated, and you put them on ECMO at the time, their outcomes are pretty poor, as opposed to someone who's present with 2 days of symptoms, came into the hospital, got intubated on the same day, and so these patients have the highest benefit. So an ideal patient who is young, single organ involvement, very short pre-intubation illness, and a short ventilator time. So the patient usually should be on less than 7 days on the ventilator, for them to be able to benefit from ECMO. So now we are extremely selective in which patients we pick to put them on ECMO. One of the reasons is also ECMO availability, and even in places where there is an ECMO center, the resources, how many ECMO machines they have, and with the pandemic, with so many patients coming in with similar presentations and hypoxia and ARDS, you won't be able to offer ECMO to every patient, and then you have to pick which patient you're going to offer an ECMO, and which is a big ethical question. So it always helps to form a team in the hospital, involving the critical care physician, involving the cannulating surgeon, the perfusionist, the ethics team, and the hospital administration, to kind of come up with some criteria to pick which patients you will put on ECMO. There should be pretty stringent criteria, again, for the same reason as we talked about. You could be doing more harm than benefit by putting them on ECMO if you pick a wrong patient. Also, one other thing that really helped us is to have a preemptive discussion with the family about expectations after cannulating. So it's very easy when you have a discussion with the family, and the family obviously will say, do everything possible to keep my mom alive, dad alive, and you put them on an ECMO, and now there is no improvement, and when you are ready to take off the ECMO because of the futility, then it's an extremely difficult decision for the family to make. So it's always good to have a discussion with the family prior to cannulating, and have a set goals. And we usually say 7 days. We'll give them an ECMO support, and if we see an improvement at 7 days, we will continue longer period of time. If we do not see any improvement by 7 days, or if they develop any complications, bleeding complications during the run, then we stop the ECMO run much before, and that usually helps the family to understand and agree with your decision, because cannulating is easy, decannulating is the most difficult part, especially when the outcome is bad. Now, this is a picture of a configuration of a typical veno-venous ECMO. It's on the right side of the picture where the box is enlarged. You can see that's the right atrium and SVC and an IVC. On the top, SVC, you have the return cannula where the blood is flowing and towards the tricuspid valve into the right ventricle. And this is the drainage cannula that's coming from the IVC, the hepatic veins and IVC. So the blood is drawn from here, and so we go here. So this is the blue blood. So the drainage cannula takes blood from the IVC and then goes to the pump in this console where we set up. And this pump, pushes the blood into oxygenator. And this oxygenator is also connected to a blender which is supplying oxygen. So the blood and oxygen are on both sides of the filter where the gas exchange happens. And the oxygenated blood is given back from your SVC into your right atrium to your return cannula. So, and then the blood mixes here, into the right ventricle, your native blood and the oxygenated blood, both of them get into the right ventricle, go into the pulmonary circulation, left atrium, and then get supplied to the rest of the body. So it's a very simple mechanism where you take the blood out, you oxygenate, you take the CO2 out, and you push it back into the human body. Theoretically, it should work, but there are lots of caveats to it. One of the big problems with COVID patients, at least the theoretical problem, was when the blood runs through the circuits, there is a damage to the endothelium, and there is a cytokine surge that can happen just from the blood being exposed to this foreign body in the catheters and tubings and the filters and stuff. So if the patient is already going through a cytokine storm, and you put them on ECMO, can you make it worse? So that was one of the big questions, and people did die in the beginning after they went on an ECMO run, and due to severe shock and inflammation and multi-organ failure. And one of the proposed theories was that. So it comes with its own problems. Bleeding is one of the other things. Is the problem. Many of these patients need full anticoagulation while they're on the ECMO run, and they can have DIC and bleeding issues and stuff. So there are some problems with the VV ECMO, but in cases where it's a young person and you have no other choice, then ECMO is definitely a place to explore. Early versus late tracheostomy. So once the patient is recovered to a point where his oxygenation is better in a low ventilator settings, but we cannot extubate him because say he's been on the ventilator for 20 days, a month, and he has critical illness, neuropathy, myopathy, or he's been on heavy sedatives all this time, and he cannot be extubated, then we need to decide on the tracheostomy. Just like everything else in the beginning of the pandemic, all the surgeons and intensivists and anesthesiologists were trying to stay away from tracheostomies because of the high risk of spread to the healthcare workers. But now with better understanding, better PPEs, also now we know that the infectivity of these patients, despite having a positive test, is pretty low after 10 to 14 days. So all these things have increased the comfort level of the people doing tracheostomies. And, we usually do 10 to 14 days from the time of the ventilator initiation, tracheostomy, if their oxygen requirements have come down. One of the big problems is the uncertainty in prognosis. Some of the people, patients progress to die, then is there a role in doing tracheostomy in these people? So that's a debatable question. So again, having a hospital policy and having anesthesiologists, the surgeons, intensivists together to kind of establish certain standard of care is always helpful in these decision makings. Pronation, I think one of the interventions that has shown a significant mortality benefit even before the COVID-19 in ARDS patients was proning. This is no medication, there's no A very simple technique where you prone the patient for 12 to 16 hours a day. So the criteria is the patient should have moderate to severe ARDS, usually means a PaO to FiO2 ratio of less than 200. Or if they don't have a blood gas, you can go by a saturation by FiO2 of 235. The biggest trial that showed the benefit is the PROSEVER trial, which showed a huge benefit for patients who were prone with ARDS. The key is to be able to prone for 12 to 16 hours a day. That's a lot of time. So they are more prone than unprone, during the initial days of ARDS. There are some contraindications. A couple of absolute contraindications are someone who has a spinal instability or someone has raised ICP. Those are probably an absolute contraindications to proning. And there are other relative contraindications: burns, facial injuries, open abdomen. But I think those, and obesity, but those things are probably, again, you can do a risk benefit analysis to see if if you have to prone them. But if someone has the much before COVID showed some benefit transiently, but not for long. But these patients in this trial were only prone for 5 to 8 hours a day. Then during the COVID, there are multiple small case series and small studies that came out, which all showed that patients can do self-proning, and some of them got a benefit where they did not progress to severe ARDS and did not have to be intubated and recovered. So there's more and more evidence gathering for proning patients even when they're not intubated. So we usually encourage patients, whenever the nursing goes in, to prone, most of the day. They might not be able to do it for 16 hours a day, but we give them usually a 3 hours proning, a half an hour break, a 3 hours proning, that kind of a schedule. So that way they have a clock in their rooms and they know when to prone and unprone. And we've seen some good results with that. You can prone with a simple cannula, a high flow nasal cannula. BiPAP sometimes, yes. So that's a little tricky. Patients may need help adjusting the tubes when they're doing the proning if they're on BiPAP or CPAP therapy. So that basically ends the questions about the COVID patients. Now, in the last 3 slides going forward from here are all our management directions which we have in place at our hospital, which is all similar to what we talked before. Again, if you see a saturation less than 92, we start with a simple nasal cannula. If we see an increased work of breathing or dyspnea, or if they require greater than 6 liters, we switch them to high flow nasal cannula. If they have increased work of breathing and you have to blow out a CO2, then we switch them to a CPAP or a BiPAP support. Venturi mask, we usually don't use it. Inconvenience for the patients and no added benefit over high flow nasal cannula. Accepting a lower oxygen saturation is a difficult culture that we had to explain to the nurses, to the respiratory therapists, to the other doctors. When they look at a monitor and see a saturation of 85, it's okay as long as their delivery to consumption is greater than 2:1. One of the things that we follow is clamping the ET tube while intubating patients. Now it does one thing, when you're intubating, if the patient has a little cough, aerosol can come through the ET tube and your face is right there. So we clamp it. The only disadvantage is you cannot put a stylet in it if you clamp it. So we intubate patients without stylet and clamp the ET tube at the other end to reduce the amount of aerosolization during intubation. Anytime there is a circuit break, if the tubes are filled with secretions and blood and needs to be changed, also you can clamp the ET tube. That way you maintain the peak and also to minimize the aerosol generation during the time. Ventilated patients, as we mode of ventilation better over other, we determine based on the patient's respiratory mechanics and the goals of what we need, less than 6 ml per kilogram. and keep their mean air blood pressures less than 30 centimeters of pressure, and permissive hypercapnia. And then the PEEP is we basically determine the lung compliance of the patient, and then we decide how much PEEP whether we're going to use a high PEEP table or a low PEEP table for a given FiO2. We try and avoid spontaneous breathing and a lot of patient ventilator desynchrony after we intubate the patient, usually after the first 24 to 48 hours. So you may have to use a higher amount of sedatives or sometimes even paralytics and try to control the ventilation and avoid the excessive breathing, and also to avoid the desynchrony that can cause patient-induced lung injury and other problems, hemodynamic problems. Once things have settled down, then we back off on the paralytics and then slowly lower the sedation. We've used inhaled nitric oxide, I should say, quite often while waiting for a patient to be cannulated to go on an ECMO or to other rescue modalities. Inhaled nitric oxide can buy us time. It can improve oxygenation transiently for a day or so, but does not change big time mortality. So we do have it available, and we do use it in patients where we have to buy a little time, but this usually does not provide a long-term help or a mortality benefit of inhaled nitric oxide. In COVID patients, there might be an additional benefit of inhaled nitric oxide where it does the pulmonary vasodilation and can help the VQ matching and lower the oxygenation also. Last part is the VV ECMO, as we talked, and we prone all patients with ARDS, moderate to severe ARDS patients. And that will end the topic here. Okay, Arun, you still there?
Yeah, Prashant. It was a wonderful, elaborate discussion. Yeah, Prashant. Yeah. Dr. Subbareddy, yeah, you can continue.
Arun, Dr. Subbareddy?
Yeah. Thank you, Dr. Prashant, for that excellent talk, excellent elaborative talk on management of hypoxia in COVID-19 pneumonia patients. He almost covered everything, and we can we take some questions, Dr. Prashant?
Yeah. Those who want to ask questions can either type it in the public chat.
We have some questions in the chat box.
Yeah. Yeah.
Should we delay invasive ventilation as long as possible in COVID? By Dr. Prabhakaran.
Gotcha. So again, there are problems in delaying mechanical ventilation in certain group of patients. So if you see a patient with a high respiratory drive who's breathing 40 times a minute with large volumes, either spontaneously or on BiPAP, these patients have developed something called patient self-injured lung injury. And once they get on the ventilator, they already had a significant amount of damage, and probably the ARDS is now past the acute inflammation phase and into the fibrotic phase. So their chances of recovering from the ventilator or from an ECMO support goes down significantly. So if you see in a small group of patients where their respiratory drive is very high, they're breathing at 35-40 times a minute, and you don't see an improvement in the first 2 or 3 days, then we proceed with intubation and would not delay intubation in such patients. If patients are comfortable and just hypoxic, but they're okay on high flow nasal cannula without high respiratory drive, we've had patients on high flows and BiPAP for many days. So I think, again, to answer the question, one strategy does not fit all patients, and we have to be selective on which patients will benefit from early intubation. And one of them is that, and the other one is, if someone is in severe shock and multi-organ failure, we also go for early intubation in this patient.
Yeah, thank you, Dr. Prashant. And one more question. Any pharmacotherapy to stop transition from pulmonary phase to hyperinflammatory phase? And is there any role of ulnastatin?
Nothing proven by any rigorous scientific research. There have been anecdotal data or case reports about benefit of using statins, benefit of using early steroids and other anti-inflammatory agents, but how much they really benefit is yet to be seen. We do not routinely use statins, but if the patient has been on statin at home prior to coming to the hospital, we continue that, but we do not initiate statin to reduce the inflammatory phase. Now, steroids, on the other hand, yes, the recovery trial has clearly shown a huge mortality benefit in patients who are on dexamethasone, 6 milligrams daily for 10 days duration, and that probably does the same benefit where it probably cuts down the inflammation and decreases the number of patients going into the fibrotic stage. So I think that's probably the only pharmacotherapy that we use currently in the early stage of ARDS to prevent them from going into the fibrotic stage.
Yeah, whenever there's hypoxia, most of us use steroids, and more than steroids, I don't think any other pharmacotherapy will help prevention of going into hyperinflammatory phase. And his one more question is there any role of statin or similarly cytosol we use for whenever there's a cytokine storm, cytosol filters? Is there any role of these devices in cytokine storm in your experience or any evidence for this?
So we've done a few cytosorb through the CRT or dialysis, or we've even done a couple of plasmapheresis. With the whole idea was to try and reduce the cytokines and inflammatory markers, in the hope that this can reduce the amount of damage. But we haven't seen any significant benefit, and unfortunately, in the beginning, we threw everything at these patients, including antivirals and steroids, and so it's hard to tease out how much benefit we got from each of these modalities. And since we have not seen any published scientific evidence from any of these places, throughout the world, then we've stopped doing those things. So right now, no, we do not do cytosorb or statins or any other anti-inflammatory agents other than the steroids in these patients.
Yes, even I agree. There are some cases, but there's not much evidence. But cytosorb, when we started using cytosorb, the filters are getting clotted very frequently because of the thrombotic risk. You need to hike up your anticoagulation, and this is one problem. And then they may require some mild thrombolytic doses to keep the filters running. But we have not seen much benefit even with cytosorb filters whenever there's a cytokine storm, and it's waste of money, lot of money for the patients in pandemic using these things. But there are some case series, and then even the FDA has given approval, but I don't know how much evidence in future is going to come. And he asked one more question: what's the role of remdesivir? And then is there any role of steroid nebulizations in the early stage?
So I'll touch one more point on the cytosorb or cytokine storm syndrome before I go to this question. Very, very recent, I think maybe 4 days back, there's an article published in the Lancet about the cytokines, the level of cytokines in ARDS patients from COVID and non-COVID ARDS patients. And what they published is the cytokine numbers are not unusually high in COVID patients compared to other ARDS or other acute illnesses of patients coming to ICU. And this is a very recent article that was published. So the whole concept of cytokine storm syndrome may itself be, debatable. And I think there'll be, I know there's lots of places that are doing studies and collecting blood and measuring these cytokines and stuff, but we might get more evidence pretty soon, which might, sway us away from using these things to kind of trying to cut down the cytokines. Going back to the remdesivir, so again, I think currently we have two studies, two big ones, which showed some benefit of remdesivir. The first study, which showed that the acuity of illness and the hospitalization was lowered from 15 days to 11 days. So there was a 4-day benefit of illness by using remdesivir, but no mortality benefit. Now, that is some benefit to some patients. So we do use remdesivir for every COVID patient who has moderate to severe disease. And if, again, when you use steroids, remdesivir, and other therapies, it's hard to kind of say how much is going to work. Looked at whether 5 years, and there is no idea. German study on moderate ARDS patients or moderate or COVID-19 moderate disease people. They've used remdesivir, and interestingly, again, it showed that the 5-day there is a benefit. When you use it for 10 days, there are actually no benefit. So it really logically does not make sense unless remdesivir longer doses is causing some problem. But if there was a benefit in a 5-day course of remdesivir, you should see the same benefit, even 10 days, if not worse. But 10 days, there is no statistical difference in the benefit if you use remdesivir. But if you do a 5-day therapy, there is some benefit according to this study and the previous study. So we do use remdesivir.
If you look at the cost of favipiravir and remdesivir, both are expensive. Favipiravir is expensive and remdesivir is expensive because these patients have to get hospitalized to get remdesivir right now. So remdesivir taking home care therapy still not accepted. So, but I have seen in most of the places they use remdesivir even in mild cases, which is not required unnecessarily. We are making patients to spend more and more money. So if it's a moderate to severe disease, and we can use remdesivir. There's no difference between 5-day course versus 10 days course. Dr. Prashant said, so we should use judiciously. There is a pulmonologist who used budesonide in COVID-19 patients, and then he showed some benefit, but otherwise no much evidence for steroid nebulizations in the early stage. Dr. Prashant, do you agree?
Yes, we do agree. We do not routinely use it, but if someone has underlying lung disease like asthma or COPD and come with COVID pneumonia, then we do inhale budesonide or nebulized budesonide. But routinely for patients who have known lung disease and who's taking dexamethasone, we do not use budesonide. The only exception we probably did for a few patients is someone who comes with a severe DKA and we cannot give initially high-dose steroids. We do 1 or 2 days of budesonide until blood sugars are better controlled with the insulin drip, and then switch them to systemic steroids.
So there are no more questions in the chat box. Shall we wind up, or Dr.
I think one Dr. Vishaka is typing a question. We may just wait for her.
Yeah.
So I think
when to start anticoagulation? Dr. Vishaka is asking when to start anticoagulation.
Prashant.
Yeah, that's an extremely difficult question because we've had multiple debates within our. Yes. Hello?
Yes.
Yeah, Prashant, please.
You can hear.
Yeah, Prashant.
Circulation. Again, we've been back and forth with whether should we start preemptive anticoagulation based on D-dimer levels. Some institutions have adopted policy. Hear me?
Yeah, we can. Yeah, please. Yeah.
Okay. So again, we in our institute, if there is a proven DVT or a PE or a very high clinical suspicion for one, and we cannot scan these patients, we start full dose anticoagulation on these patients. If they do not have either one of those conditions, we only do a prophylactic dose of either Lovenox or sub-Q heparin on these patients. We do not start empiric anticoagulation in patients with elevated D-dimer. There have been a couple of studies also recently where there are poor outcomes or increased mortality when you start anticoagulation without any diagnosis of a proven DVT or PE. So we at our institute, we do not start anticoagulation unless patient has a proven DVT or a PE or a very high clinical suspicion. If someone on ARDS or on the ventilator and has a fixed FiO2 for a few days, and then you suddenly see a jump in FiO2, and that's not explained by chest X-rays or other clinical features, then we start them on anticoagulation with a suspicion for PE, but not just based on a D-dimer level.
We are seeing more and more anticoagulant-induced complications, upper GI bleeds. The combination of steroids and anticoagulants are causing upper GI bleeds, and even we have seen intracerebral bleeds with anticoagulants. So, some people, they use very high dose of anticoagulants without any proof of pulmonary thromboembolism or DVT. So that is again we have to be very careful. And we have one more question: when dexamethasone is started, early or late, once they become dyspneic, or when do you start dexamethasone?
So we follow recovery trials recommendations, because that was the largest study which showed benefit of steroids in COVID-19, and their inclusion criteria, the patient does have to have oxygen supplementation. So anyone who requires who has hypoxia, we use dexamethasone. Someone without hypoxia and has fevers, myalgias, or GI symptoms, we do not use dexamethasone. So at the point where the patient is requiring supplemental oxygen, that is the time when we start dexamethasone, and we usually again do 6 milligrams either IV or PPO, one dose versus divided doses for a total of 10 days duration.
So again, there is no role of prophylactic usage of dexamethasone to prevent hypoxia in these COVID-19 patients. People are using dexamethasone even on OPD basis and to prevent hypoxia, but definitely there's no role during viremia phase when they are not requiring oxygen. So we have to avoid giving dexamethasone. Once they start requiring oxygen, so that time we have to start dexamethasone, as Dr. Prashant said. So
true, and it can be harmful theoretically if in the beginning phase of viremia, when you're not hypoxic and your body is trying to fight the virus, and we're suppressing our own antibodies or our own immune system to initially curb the viremia. So I think we should let the body deal with its defense mechanisms in the beginning to try to cut down the viremia. And if they come to a stage of lung involvement and hypoxia, I think that's probably where the role of dexamethasone is. So I strongly discourage, even here, or even my family members back in India, many people have asked, should I start dexamethasone? I'm at home. And some people even just contact with other COVID patients and with no symptoms, have dexamethasone at home and using it. And I think we probably should hold back that urge to treat these patients until they actually become hypoxic.
Prashant, there was one question initially where we had a technical snag. During CPAP oxygen therapy, the saturation is maintaining between 94 to 96, but the patient is tachypneic. So do you consider mechanical ventilation, and what is the criteria?
Okay, so if we cannot match patient's work of breathing with the non-invasive mechanical ventilation, then yes, that is an indication for intubation. So if you put someone on CPAP, even though their saturations are maintained, if they're clearly dyspneic and breathing again, 35, 40, and pulling large volumes, and those are usually the signs of long-term lung damage in these patients because of this significant respiratory effort and the inspiratory drives. So those patients, we intubate. So we give them time on CPAP and BiPAP, probably for half a day, and see how things go. If they settle down and their breathing gets better, then we kind of hold off on the intubation. But bypass settings, if that hasn't cut down the dyspnea part of it, then then we go for intubation.
I think there are no more questions on this topic. So thank you, Dr. Prashant, and thank you, Dr. Subbareddy, who's one of the most elaborate discussion as once again said, it was very it was a pleasure. More webinars from your side on more interesting topics.
Okay. Thank you, Arun, and thank you, Dr. Yeah. Thank you, Dr. Subbareddy. And I again apologize for the technical issues that we had in the beginning of the presentation.
No problem, Sabir.
But
The presentation has overridden all the technical snags. I hope Dr. Subbareddy agrees with that.
Yes, yes. We all really enjoyed your talk and very informative. Thank you so much.
Thank you all. Thank you so much.
Thank you, Prashant. Have a wonderful weekend. Thank you very much.
Thank you.
Thank you all the participants for this wonderful participation. Thank you. Thank you, Dr. Subbareddy.
Thank you.